that way we can have this posted for on our YouTube channel. Thank you everyone for coming. Welcome on Monday. This is our second stakeholder meeting with me as the coordinator, so I appreciate everyone being able to join. I know we've had quite a few changes, so I'm excited to give some updates about everything Marcus Alert related and share where we're at as a state, both with the Department of Behavioral Health and the Department of Criminal Justice Service. So here's our overview of our agenda. We'll do some state updates. We have some data updates, a few presentations about some of the projects and intersections with Marcus Alert, and then we'll have our regional updates as well. All right, so some state updates. As I have met some of you either as site visits or in some form or capacity and working under Marcus Alert. My name's Emily Grassi. I'm the new Marcus Alert coordinator, started back in November. So almost at my year mark. And so this is where, as a Department of Behavioral Health, where we're at, we're working on the annual report. So that's kind of in full spring. It's due in November. So I'm sure it will be available for everyone who's interested in reading after. We have also been working on making our local plan guide improvements. We have heard a lot of feedback from those CSBs that have implemented or are currently implementing, and we know that there's some confusions about requirements and optionals and wanting some more description and some services in place to help with implementing Marcus Alert. So we're going through the review process to make that available to everyone coming up. In addition to that, we started some research projects earlier this year in the development of our Marcus Alert training. And from that, it's allowed us to also partner with some other universities and agencies who are interested in researching some of the implementation components, co-response components of Marcus Alert to see where we can improve. So we don't have any official research projects to share at this time, but we are in the process of seeing what ones are available, and we hope to have some more to share at our next meeting. So that's on our side. I'll pass it over to Rick Collins and Ashley for them to give their state updates for the Department of Criminal Justice.
Thanks, Emily. Good afternoon, everybody. Hopefully you guys can hear me okay. I'm in a different office today, so hopefully it's not an echo too bad. As Emily said, my name is Rick Collins. I am the Standards and Policy Manager for the Law Enforcement Division here at DCJS. And Marcus Alert is one of the areas that falls on that standards and policy side at DCJS. I'm filling in for Dallas today. Normally he would be here, but he had an emergency he had to take care of. So I'm filling in for him. And we just have a couple of things that we want to share, which you see on the slide. And you see DCJS new roles. I think, as all teams do, continue to evaluate what everybody's doing and what their responsibilities are. And also, like all teams, there's always continuing piling on additional work. We're often victims of our own success. So we don't really have new roles. We just kind of evolved some of our responsibilities for the Marcus Alert team. When that team started, they were primarily focused on Marcus Alert. We were very fortunate to have Dallas and Ashley join the Marcus Alert team from the DCJS side. And they come with some pretty unique backgrounds that have allowed them to expand kind of their responsibilities at DCJS and in the Commonwealth to some different areas. So we have expanded those roles. Dallas was our Marcus Alert coordinator. That was his official title. We kind of reevaluated some things and stuff that he was involved in, and his new title is the Law Enforcement Mental Health Programs Coordinator, and that does encompass Marcus Alert. So he is our team leader from the DCJS side for Marcus Alert. But those of you that I'm sure know Dallas know he keeps himself busy and has his hands in a lot of things, and so under that same umbrella, Dallas is working alongside with the Virginia CIT Coalition for some CIT responsibilities. He's heavily involved with VA LEAP and peer support. So we kind of modified his position to encompass all of those areas. And Ashley was a Marks Alert specialist, but she comes from us with a communications background that's been hugely beneficial to this team. So her new title is a Marks Alert and communications specialist. And then we hired an additional person. We were very lucky to hire Patrick Long. He is the Marcus Alert and CIT specialist. He comes from us from DOC, which has been really great for us because Dallas's background is law enforcement, Ashley's background is communication, and now we have Patrick, whose background is DOC. And so that gives us a lot of unique perspectives that I think are really important to this team. And he's under the weather, so he would have been here to introduce himself. So I'm stealing his thunder a little bit from him, but it's been great to have them. We've been very fortunate to kind of modify their roles and have them be involved in some more things across the Commonwealth that we think has been very beneficial. The other thing you see on the slide is the Virginia Co-Response Conference in June. Earlier this summer in June, a number of us from DBHGS and from DCGS attended the International Co-Responder Conference in Denver. And one of the things that I'm sorry, not Denver, in Omaha. Getting my conferences mixed up. But one of the things that we talked about heavily while we were there was, would Virginia benefit from a co-response conference and an opportunity to take some of the things that we learned at the international conference and make them Virginia specific and bring them to Virginia. We have some funding available to do that. We are in the very earliest of stages and planning that. We have a target of maybe late spring, early summer next year. And so I don't really have a lot of information to share on that, but I wanted to make sure that at least we put it out there, let you guys know that that's something that we're working on, and certainly welcome ideas and suggestions. And I think as many of us on this call have attended conferences or have been involved in planning conferences, how much work goes into it and how key it is to find good presenters and people who are on topic for Virginia specific needs. So if you have those suggestions, are interested in being involved, I think certainly let me know or let Patrick know or Ashley or Dallas or any of the DBHDS crew. And when we get some more information, we'll share it. So that's all I have. Ashley, anything?
I don't have anything to add. I think you covered it.
Awesome.
All yours, Emily.
Great. Thanks, guys. We appreciate it. So, and then looking at where we're at a state and statewide Marcus Alert implementation, kind of at bird's eye view. I know each of our regional coordinators will go a lot more in depth, but just wanted to show a quick snapshot about where we're at. So we have 17 CSBs who have implemented. Of course, as part of the implementation process, we know that there's there's 3 protocols that each CSB has to go through. Part of that is diverting calls from 911 to 988, having mobile crisis respond to lower level behavioral health calls. But also for the higher, more emergent level Marcus Alert level calls, I thought it would be important to have a overview about, generally speaking, where we're at in our team compositions. Again, this is just very generalized. There's a lot of differences even within these team compositions. We have, even if they are a clinician in law enforcement, they may not ride in the same vehicle. Law enforcement may respond and have a clinician on standby via tablet or some form of telehealth platform. So it's very diverse and unique, and it's really exciting, the thought of having a co-response conference for all of us to get together and for some of these CSBs to share some of their successes, and again with the research projects evaluating if there is one that seems to be more impactful than other composition types. So it's just exciting to see as we continue to grow as a state and implement Marcus Alert, how each community is taking it on and making it their own. And so, yeah, just want to share that information about where we're at in our implementation. So some data updates. There's a lot of data updates for the state. So obviously with 17 CSBs implementing, there is a significant amount of 911 dispatch localities affiliated under each jurisdiction. So we now really have increased our partners providing data across the entire state. And part of our annual report, our data analysts are really working hard to run different reports to see how we can showcase with numbers and obviously with verbiage as well. How is Marcus working? What's the progress? Where's the positives? Where are some of our barriers? And how can we make those changes as a state? We're also having data changes for where we're collecting the data from what partners, but we'll go into that in the next couple of slides. A few reminders, Q1, it began on July 1st, and Q2 will begin October 2nd. The data is required to be submitted to this email address on the screen 45 days at the close of the quarter. And then also just a side note for our data analysts, we're still working on trying to get all of the data that has been submitted together. So some of the jurisdictions may be incomplete. And so the data that we are going to present today are also partially incomplete. Just a note there. So some of the changes really to the format of the 911 dispatch collection template. We have kept most of it relatively the same, other than just how you would operate the data template. Some of the main changes that we have are the call response disposition options. We've kind of expanded them some and made it match up to another area that we're going to focus on collecting data, which is from our co-response that we just mentioned at the beginning. So all of the CSBs who have a co-response unit, we are going to start collecting data from that. Reason being is that we want to make sure that we're really capturing all of what Marcus Alert is and what is not for our annual report. We want to make sure that in doing so, it will help us make whatever training changes we need to hopefully get some funding changes and just see, how can we improve Marcus Alert, and where is it working well and where is it not working well? So both of our co-response data template and our PSAP template are in the very beginning stages of being implemented. So I'm sure as many of you on this call are familiar with data, it has to go through various departments and agencies for review before we can start requesting it of any of the agencies. So we have finalized what we are going to be passing on to Reeds and quality and assurance for them to review. So it's still very early on, nothing official, but these are some of where we landed on what we're going to start having co-response units collect. So PSAP number, date of call, time dispatch, time cleared, Marcus Alert level, the call response, and the disposition at that time, behavioral health type, whether or not the individual was under the influence, whether or not there was an intellectual or developmental disability, if so, was REACH contacted, if there was an injury involved, if so, who, and again, that is specific to whether it was a clinician or community member or law enforcement, not looking for personal information, age, race, ethnicity, and homeless status. And then, so here are some of the data that we have collected so far for fiscal year 24. Again, our data analyst is still working to go through the entire year, but for quarters one, she has broken it down for Marcus alert levels, and then just calls by disposition. So it seems pretty consistent with what we would anticipate being dispatched based off of Marcus alert levels. Levels one would go to 988 or 911. Levels 3 or 4 would obviously have more of that law enforcement or emergent um, first responder component to it. So, yeah, that's been pretty interesting. And then some other things that they have worked on is seeing calls over time. So seeing if there's particular days, hours of the day, or times of the year where we see higher call volumes than others. So that's been broken down, as you can see. August, or towards the end of July, I'm sorry, mid-July, calls for Marcus alert levels 1 had increased, whereas prior to they weren't. That's also due to new jurisdictions being implemented in July 1 as well. So some other interesting factors to look at there. Oops, sorry, I went backwards. And then also for quarters too. So again, seeing how does it look over time. Okay, I'm going to go ahead and pass it over to Felicia Jefferson. She is the head of of the multicultural counseling group project. That is one of our project at Intercept Zero, Equity at Intercept Zero. So she can explain some of the work that she's been doing and how it's working to improve the goals outlined in Marcus Alert. Let me see. Felicia, are you here? Oops. Thought I saw her on the call. Let me see. Mm, Give me just one sec.
Emily, there's questions in the chat about what you just went over too before Felicia starts, if you want.
I'll go ahead and save the questions for the very end so that we can get to everything all at once.
Okay.
Sorry about that. Let me unmute her. My apologies, it's a very long list. There we go. Hmm. Mm. Okay, I apologize. Give me just one second.
I'm sorry, I wasn't able to unmute, but I'm unmuted now. Can you hear me?
We can, yeah, thank you.
Thank you very much. I'm sorry about that. I'm not that
Okay,
familiar with Teams, but I did find my mic and I was able to unmute. So if you can put the slides back up, if you
yes.
can.
Oops, give me just 1 second. I had too many screens open.
While you're doing that, I would just like to share with the group that although we're not directly involved with the mobile response teams with the Community Services Board, our mission with the multicultural group, counseling group, is to provide, to increase the availability of licensed clinicians to work alongside the law enforcement authorities. And for the multicultural counseling program, or the, yeah, there we are. For the equity and intercept zero, one of the focuses that we notice is there's a 5-point area, 0 to 5. And so we focus in on the area of training opportunities to increase the participation of providers of color in crisis services, and also to increase the number of students of color seeking jobs in crisis services. And one of our components in doing that is our mentoring program. Um, our target population, of course, is the BIPOC population, because the data identified that there is a significant disparity of people of color, licensed clinicians of color throughout the entire state of Virginia. And so we have in our program um, 44, we're serving 44 clinicians, resident clinicians. And in that population, we are serving African American. We even have individuals who are African that are residents and citizens of the United States in our group, Hispanics and Asian Americans. You can go to the next slide, please. And so the FailSafe project, which is basically our umbrella, we are FailSafe is connected to or collaborates with the criminal justice system, where we're providing services for populations who have been, families and individuals who have been impacted by incarceration. Our focus is on the community service component and also reentry. Go ahead to the next slide, please. So FailSafe is a 501c3 corporation. The organization provides services to enhance the quality of life of families impacted with incarceration. One of the key components of our services is the mental health support. We go into the jails to prepare individuals to return to the community, and we provide them training on various areas for them to be successful, to decrease the recidivist rate. And the component that I'm over is a multicultural counseling group. I'll go ahead to the next slide. And with the multicultural counseling group, as I mentioned earlier, the focus is to target the BIPOC population, to support them in their initiatives in getting licensed by the state of Virginia as a marriage and family therapist, or a licensed professional counselor, or a clinical social worker, licensed social worker. And so our team of supervisors are individuals who are veterans of the profession. They've been in the profession for more than 10 years. They have to have been licensed for 3 years or more in order to be a clinical supervisor. And you can go to the next slide. And then we're just so pleased about the success that we are experiencing. I took over the project in March. Prior to my coming on board as coordinating the project, I was a member of the team of clinical supervisors. We have two particular areas that we focus on with the multicultural counseling project. One is mentoring and coaching students that are still in college, and also going into the high schools to raise the awareness and understanding of the mental health profession. The clinical supervision component It's our largest component. We had projected to serve 36 residents for the duration of our project, which was written to be 1 year. And so we are already served over 44 individuals. And the reason we've been able to serve 44 individuals because we have supported, since it was an extension of the project that Lori Wilson had, those individuals basically transitioned over to the multicultural counseling group, and the residents had already accumulated significant a number of hours. So as they accumulated significant number of clinical supervised hours and went on to take their licensing exam, that basically opened up another slot for another resident to enter into the project throughout its duration of that project. I think what is so unique about our services is that we're not only supervising residents, but we are supporting and mentoring our residents. And we are, this year, one of the components also is to provide training whereby we would invite all of 44 residents in for specialized training. We noticed that there is a significant deficit in diagnostic work. So we're focusing our training on diagnosis and treatment and also on ethics. So we are very proud of what we've accomplished at this point. And we know that, go ahead to the next slide. We know that, go ahead forward. Well, I don't need to address that one. The Boost 200 project was basically, targeting at least 200 LCPs or licensed practitioners. And already with the little small component that we serve, we've already identified and supporting 44 residents. And we just anticipate a very effective outcome with our project. Go ahead to the next slide. Thank you. So, and you can move on to the next one. I basically have mentioned that. So the project was proposed 34 residents. We're already serving 44 residents. We have 3 LPCs that have been licensed, and I know there are MFTs that are getting ready to, and clinical social workers that are getting ready to take their license exam. And some have already taken them, and there were some difficulties in passing. So we identified a need to provide some training to enhance the outcome of those who are testing. But that's it in a nutshell. I'm willing to respond to any of your questions, but as you go forward with the Marks Alert project needing licensed clinicians, we are here to help you fill that gap to make sure you have not just licensed clinicians, but competent licensed clinicians. And we're really proud of our work.
Thank you. Thank you, Felicia. We appreciate it. It's always exciting to hear the updates and the project outline. It's very exciting work, and we appreciate what you guys do in your region. All right, we're going to go ahead and pass it off to Laura Clark. She is the Chief Operating Officer for HopeLink, and she is going to provide us with some 988 updates.
Good afternoon, everyone. Can you hear me okay? I have new headphones today. Awesome. Okay, so you can just go ahead into the next slide. I am overseeing the Crisis Services Program at HopeLink. We are the Regional Crisis Call Center for 4 of the 5 regions, 1, 2, 4, and 5. And Frontier Health covers Region 3. My goal here today is just to provide more of an overview at the state level versus at the individual center level. So I just wanted to start with kind of the umbrella, the bigger updates impacting 988 across the network. A couple of new things are coming out. We all centers were required to sign a new network agreement, which is expanding Vibrant and SAMHSA's oversight in our data collection and storage, how state and local programs are utilizing 988. There's some updated service delivery standards and some new training of compliance requirements. All centers were required to sign by the end of July, and all changes go into effect November 1st. So we have a little bit of ramp up time to implement some of these things. There are a couple of other elements that go into that I didn't list, but some of it is around marketing, that we are, what we are allowed to do and not do around marketing, things like that. What's going on kind of beyond vibrant and more at the legislative level is we have the geo routing requirement for the FCC, which I'll talk more about. There is a bill for funding for follow-up contacts happening 24 to 72 hours post initial call, which is a 988 requirement, but it's not currently funded in any of the federal packaging. And a national requirement for university and college IDs to have 988 local crisis lines on the back. And I know that's something that Virginia in general has kind of already had good support for. So those are what we're expecting at the national level. Next slide, please. Really excited to say that geo-routing is coming. This is something that we have been talking about for a very long time and really impacts our communities greatly. Geo-routing is not geolocation, but it is a step in the right direction. Geo-routing puts people in contact with their local center based on their geographic location versus their phone number. There's kind of levels of this that went through the FCC, and it was ultimately chosen to move to geo-routing to protect the precise location of help seekers and not kind of holding us back from the function of a 911 center. So I think that's important. Next slide, please. So August 12th is when we became aware of what our level of impact would be for our center. And HopeLink is a highly impacted center, and as well as Frontier, meaning that we are expecting a greater number of calls than we're currently being routed. Right now, we are preparing for the activation of the 3 largest carriers, which begins in mid-September, with the final carrier activating at the end of October. So that will bring us a better understanding of what our actual local volume in Virginia is, as we have been serving lots of folks living outside of Virginia and vice versa. So it's a really important step to ensuring that people in Virginia are getting Virginia responses to behavioral health concerns. Next slide, please. So just kind of showing a very basic graph of what our call routing looks like currently from last July until this July. The darker blue line is routed and the lighter blue line is answered calls. What really caused this significant shift is in December, the change to mobile crisis, that the call centers are kind of the front line of mobile crisis requests. The dip in February isn't really a dip, it's just a shorter month. So if we were to compare average calls per day, you would not see a dip in that. But we are reaching historic volume. We've been kind of in this pattern for quite some time. In July, we had almost 15,000 contacts routed to the state. What's really interesting about this is that Virginia is the 13th highest in population, but it's the 6th highest in volume across the nation. So we have a lot of calls coming into 988 and trying to better understand, is this only mobile, or is our marketing ahead, and kind of what's chicken or egg? What is causing these increases? But it's an interesting increase for sure. Next slide, please. So just as a reminder, kind of how our workflow works in Virginia, we have kind of the 4 possibilities of call resolution. Essentially can be resolved at the call center, or you could be warm transferred to another service, which is the overwhelming majority. Something like 92% of calls are being resolved with us. Some calls are moving to care navigation for complex behavioral health referrals, and a portion is going to mobile dispatch. And then the final layer being first responders, including co-responses, level 3 and 4s, which is about less than 1% of the volume that we're working with. This data is getting better and better, but we're still kind of working through how we define resolution. And just kind of as a note for PSAP diversion, I believe last year we had about a little over 2,000 calls diverted from 911 to 988. And in August, and this is again just HopeLink, not necessarily what Frontier is accounted for. In August, we've already had 104 diversions, and that is due to the onboarding of several new 911 centers. So a lot of growth, a lot of room for continued growth. We have continued capacity challenges that we're partnering with regions and states on. But overall, people are being served better and differently, which I think is important. All right, next slide. And this is my last one. Just as a kind of a note, most calls that don't require further intervention that are resolved at the call center are lasting about 13 to 14 minutes. Frontier, I think it says 12 to 13 for theirs. Average speed of answer for 988 Virginia is about 14 seconds. And for HopeLink specifically, for PSAP transfers, it's about 8 seconds that people are waiting. So that really is about 2 rings before we pick up. We have a dedicated staff that's answering only the 911 diversion calls. And something of note is that when we're talking about a crisis call specifically, so somebody who is in active crisis, not just needing emotional support, those calls are about 31 minutes without mobile crisis and about 47 with mobile crisis response. So that is kind of where the capacity challenges that we're talking about at the state level really come into. How do we reduce some of the time that's on these mobile crisis response calls, but not reducing the quality of interaction? So we're working on workflow and processes around that. So that's all I have. It's a lot. There's a lot of content that I didn't cover, but I just want to make sure you all had the high level of how 988 is going in Virginia.
Great. Thanks, Laura. And I'm sure some may have some additional questions. So like I said, we can save questions for the end. But we appreciate that. I know that there is a lot of interaction with Marcus Alert and 988, but yet we're not really always directly working with one another. So I thought it was important to start including some of those updates and vice versa. So thank you. Okay, and then I will also pass it on to one of our content developers that we have hired to create the curriculum for the Marcus Alert training. I'll let him go into kind of some of the components and all of the work that we have been doing together. So Todd, whenever you're ready.
Thank you. Oh, you got the slides up. You're already prepared. Thank you very much.
You're welcome.
All right, so thanks, Emily. So my name is Todd Fouts. I'm with Sedell Communications, and we have been working with Emily and the DBHDS Central Office team pretty much since the beginning of the year to develop training curriculum for Marcus Alert. I see a number of familiar names and faces on this call, so I know we've met with many of you. Very grateful for all of your contributions and input as we've been developing this. We're hoping to have this training curriculum delivered and ready for everyone by late fall, early winter. But today I wanted to share some kind of high-level research findings from earlier this year that was insight into developing the training content. This is a very abbreviated presentation from the original research deck, which was quite extensive, but I wanted to share some of the key takeaways. So you can go to the next slide. So in January and February of this year, our team conducted 46 in-depth interviews with law enforcement, PSAPs, and behavioral health specialists. We were looking for insights about understanding everyone's baseline knowledge of Marcus Alert, some specific needs for first responders, co-response teams, and crisis workers for training. We really wanted to know about situations and scenarios for Marcus Alert calls that we could use in training, as well as training topics and methodologies that would help inform the training curriculum for Marcus Alert. So here's some high-level findings from this research, and you can go to the next slide. So the first finding here may seem obvious, but that's important. What we heard was that the passing of the legislation for Marcus Alert was the easy part. Implementation is challenging. Those stakeholders that we talked to who most need the training said that they were often confused or misaligned or sometimes frustrated with the lack of guidance so far. But also in spite of that, we heard many stories about how well communities are working together to figure this out. It's bringing different people with different backgrounds and approaches together to help develop plans that are applicable for their own community. And we heard this expression many times: we're building the airplane in flight. There were several people who said that to us, and it could not be more true. but it really points to the great need for standardized Marcus Alert training. The second finding here is the Marcus Alert name itself. Stakeholders were well aware of the very unfortunate and tragic situation with Marcus David Peters. And there were sometimes some negative reactions to the name, especially among law enforcement. Many we spoke with felt like that there was a lot of finger pointing. And as someone shared with us, if we were to have the same incident today with the implementation of Marcus Alert, it's possible that the same outcome could have resulted. But, the learning point for us is we call these elephants in the room. These are the big elephants in the room. These are the issues that we want to acknowledge. We want to learn from them. We want to improve the service to our communities. And many that we talked to said that they want to move beyond the politics of this and leverage, that spirit of cooperation and collaboration among agencies to better serve their communities. The third insight here on this screen, as we began discussing implementation of Marcus Alert, one issue that stood out in many of our interviews, and particularly among PSAPs and crisis workers, was liability. As it states here in this slide, sometimes attempting to be a helper is also one of the easiest ways to go from being a hero to being a villain. We heard, well, what if a call is transferred to 988 and that person in crisis actually needed law enforcement or first responders? What is the liability of co-response? I think now more than ever, there's greater scrutiny on everyone's job performance. As someone said in the interviews, there's a camera everywhere these days. And for those in the field, it creates a sense of vulnerability and anxiety. So those are some things we want to address. We can go to the next slide. We also heard about the importance of 988 to the crisis continuum and Marcus Alert. Thank you, Laura, for your comments. I was writing down notes as you were talking. Our team here at Statewide Communications is also working on the next phase of public communications for 988. And, we understand the 988 lifeline needs its own communications lifeline. There's still a lack of awareness about 988. There's some misinformation and misunderstanding about 988. We've heard that many are not necessarily using the 988 lifeline as it was intended. There are certainly many callers who are using 988 for services that are provided by 211. But overall, there's just some confusion, some misunderstanding. Some of that confusion spills over into law enforcement and how law enforcement is involved with 988. And that varies by community across the state. But we believe our next round of public communications and advertising will do more to educate Virginians on how to use 988, as well as to leverage all the resources available in our communities. Next, there were some questions during our research about who would be facilitating the training, primarily because there were a number of questions about the law itself and issues of liability that I just mentioned. There's a great desire, I think, for someone to have a broad knowledge of the unique and different environments within PSAPs, law enforcement, and crisis workers. I think we want the Marcus Alert training to be a complement to CIT training, but not necessarily to repeat on the training from CIT, but to rather expand more specifically into the topics of Marcus Alert. Learning about different cultures and how the intersection of these various organizations who are involved in Marcus Alert will give us all greater appreciation for each other's roles, also show how collaboration can make all of our jobs a little easier, more defined, and better supported. The last point here is that the Marcus Alert training is designed to be an 8-hour in-classroom training event. Many that we spoke with in our research had a desire for this training to increase empathy and understanding for people in crisis, and further to learn how to leverage the combined resources and expertise of PSAPs, law enforcement, first responders, crisis workers to help people on the worst day of their life. And as much as that we need to provide training and education on Marcus Alert, there's also a very strong desire to learn more about people in crisis from diverse cultures and marginalized populations. That will be a key to the success. So to kind of summarize these points, some of the top implications from the research for our training is to build pride and greater positivity for Marcus Alert as a way to help Virginians in crisis, to establish trust among all the participants, to address any insecurities or negative feedback about Marcus Alert, and most importantly, I think include a range of perspectives and expertise to really increase the appreciation and understanding among one another and the various roles that we have in serving people in crisis. You can go to the next slide. So the curriculum is still in development. We have some sessions that are complete, some that are mostly complete, some that are still in progress. We've worked with a number of subject matter experts across the Commonwealth, many who are on this call, to provide our team with kind of relevant on-the-ground knowledge and situations to model in the training. This graphic here is really just a high-level overview of the various sessions we're developing. This has actually evolved a little from when we first produced this outline, but I want to share with you some of the content that we're going to include in the training are some of the following. We're going to have background on Marcus Alert and a review of the legislation. We'll have an overview of the 3 Marcus Alert protocols, as well as the 4 triage levels and their application in the field. Review of the comprehensive crisis system in Virginia. The training will hear from those who have lived experience, as well as a review of the many mental illnesses that you're likely to encounter in the field. We'll be reviewing roles and responsibilities, how we work together as PSAPs, law enforcement, and crisis workers within the Marcus Alert framework. We'll have a review of the crisis continuum of care, and we're going to have a lot of real-life scenarios from calls, and many of these calls are real calls that you all help to provide, to really understand the calls that come in from 988 or 911, the disposition of that call based on the Marcus Alert level, on the screen assessment or on the scene assessments that are made, and then kind of outcomes of those calls, which can take a myriad of options. And finally, the training will also include a number of health equity topics, reviewing the intersectionality of race and gender and socioeconomic status and so much more. We know that equity is at the heart of Marcus Alert. It's designed to help address those disparities and how mental health crises are handled, particularly among marginalized communities. So that's going to be a big part of the training as well. But anyway, there's much more to come, but we wanted to share with you today this very high-level review of the research findings and overview of how the curriculum's shaping up. Again, we hope to have this training delivered to DBHDS for activation later this fall, early winter. So thank you very much for the opportunity to share, and thank you for all the work that you do.
No, thank you, Todd. The CEDAL team has been amazing to work with, and you covered so much. We're really excited to see the final product and to have people in Virginia start going through the training. As he said, that we're shooting for late fall, early winter. There's obviously a lot of logistics, which he also touched on, as who's going to be conducting the training. We've had some other questions about who is required to take trainings, if there's going to be other alternative days and times to assist the first responders operation of ours, right? Those who work overnight, how can we assist them in getting through the training? So there's a lot of logistics here that I think we're still trying to go through as a state to see what makes sense in Virginia, but we're really excited, and we hope that it can start helping those who have already implemented or those who are going to implement have a better understanding about what Marcus Alert is. And just be a complement of CIT training. So we're really looking forward to it. We can go ahead and go over to regional updates. So I will go ahead and have, we'll start with Region 1. Erica, she can start presenting.
Can you all hear me?
Yes.
Okay, I'm on a different system than I'm normally on, and so I was concerned about being heard. Good afternoon. I'm Erica Vesley, the Region 1 Marcus Alert Coordinator, and you can flip over to the next slide. As you can see on this map, Region 1 covers the northwest section of the state. We currently have 3 CSBs, Encompass, Rappahannock Area, and Horizon, implementing Marcus Alert, with Northwestern in their planning phase. Our regional office is housed within Region 10 CSB, and there's several aspects of Marcus Alert that the Region 1 office supports. And as you can see, our area is multi-jurisdictional, so we have lots of law enforcement agencies and lots of PSAPs that our CSBs are coordinating with in each CSB area. You can flip to the next slide, thanks. So our mobile crisis teams are coordinated and dispatched by the regional office across the whole region. They've taken the lead on the creation of the Protocol 2 MOUs. The Crisis Call Center is contracted through the regional office, and therefore they process all of our 988 data. And finally, the regional office creates and distributes what we call the status report, which is a quarterly newsletter providing updates about the Crisis Call Center, as well as regional Marcus Alert updates. Next slide. Co-response and the C Recovery Peer Drop-In Center continue to be central programs supporting Marcus Alert in the Encompass catchment area. Currently, co-response has expanded to cover 3 county sheriff's offices and 2 local PDs. Our co-response leadership has attended national co-response conferences in partnership with the participating law enforcement agencies. A local co-responder academy for our new mental health co-responders was developed. And this provides some basic law enforcement safety protocols, procedures to the mental health co-responders. The C Center has become a central pillar of the recovery community, providing no cost, peer-led support for all members of the community. They host numerous sober, family-friendly events each month, as well as their everyday work of supporting and connecting people in need to local services. Since our last statewide meeting, Encompass has a local mobile crisis team up and running, as well as an overdose response unit, providing support to individuals and families through referral from local agencies. Next slide. Rappahannock area, our second implementer, so they've been implementing for just over a year now, is continuing to grow and shift their programs to best serve their area. Currently, they have a co-response program with Spotsylvania Sheriff's Office, but will expand to 2 other agencies within their catchment as they're able to staff those open mental health co-responder positions. The co-response team that's up and running has been presenting information and data about their team at roll call on a regular basis to build understanding and support for the program. Finally, some of the counties in this area have been participating in monthly collaborative meetings to continue to process challenging situations that arise and develop and share solutions with each other. And this has been, those meetings have been fantastic, and HopeLink has been a fabulous partner in that process. Next slide. Horizon just began their implementation in July, but they have a lot going on over there. Their PSAP partners began transferring calls to 988 in June of 2024. Their local mobile crisis team is now up and running and responding to calls. Horizon has also developed a community response team to provide services and follow up to referrals from Lynchburg Police Department. The clinicians and peers for these teams are in the CSB onboarding process and will begin work in the community in mid-September. In addition, a mental health co-responder was hired through a COPS grant to work with Lynchburg PD. Over their planning period, Horizon increased the number of CIT trainings offered for their dispatch partners as well to assist them in getting prepared for their Marcus Alert implementation. And finally, the progress on Horizon's Crisis Receiving Center continues to move forward. Next slide. So I have provided a very quick and taste of all the programs supporting Marcus Alert at each of Region 1 CSBs. And should you want more information, please get in touch with me and I will connect you with the correct point of contact for the program that interests you. And then here too is a list of all the main Marcus Alert contacts at each of the CSBs. Thank you so much for your time today, and let me know if you have any questions.
Great. Thanks, Erica. I appreciate it. Lots of good stuff happening in Region 1. We can go over to Region 2. I know that they have a new regional coordinator as well. I'm not sure if she will be presenting or if it will be Wendy.
I think I will be doing it.
Okay.
But we do have a new regional coordinator who is on the call, Stephanie Pryor. So next quarter, it will be her doing the reporting out. So I'm the crisis manager for Region 2. So I've been kind of stepping in and filling this while the regional Marcus Alert coordinator position was vacant. But we in Region 2 also contract with HopeLink, and then we have a contract with Easter Seals that does our Reach mobile crisis, and then with National Counseling Group, who provides our behavioral health mobile crisis. As of July 1st of 2024, all 5 of our jurisdictions in Region 2 were fully implemented with Marcus Alert. So we're pretty excited about that. And I didn't mention, but Region 2 is Northern Virginia. So that's the Arlington, Alexandria, Prince William, Loudoun, and Fairfax counties. So starting out with Arlington, Arlington was actively setting the stage for Marcus Alert long before their implementation in July. They were doing a ton of community engagement. They were having Marcus Alert quarterly stakeholder meetings. They were partnering with civic associations, historic Black churches. They participated in over 15 community events and presentations. They've also were doing a lot of marketing and creating resource guides, pocket cards for law enforcement and first responders, Marcus Alert marketing campaigns, posters, video series, etc. And then they also were doing a lot of research. They held 5 different focus groups that encompassed a large variety of stakeholders in Arlington County. And then finally, they were really working on education and training. So they added a Marcus Alert segment in their CIT training. They were doing some educational roll calls with police and law enforcement. They were training their ECC, so their PSAP's Emergency Communications Center. And they modified the EMD mental health card. Next slide. So as I mentioned, they did implement July 1st in 2024. So they used their Marcus Alert funding to fund 5 new positions to make up the mobile outreach support team, which they're calling the MOST team. And on that team is 1 full-time behavioral health therapist 3, which is a higher level supervisor type, I believe. 2 full-time behavioral health therapists, a full-time behavioral health specialist, and then 1 full-time peer recovery specialist. And we don't have a whole lot of data yet because they just started in July. But so far, PSAPs have received 62 identified mental health calls. Of those, 21 calls were identified as level 1 and were transferred to the Regional Crisis Call Center. 39 calls were identified as level 3 and handled locally, and 2 calls were identified as level 4 and handled locally. Moving on to Alexandria City. Alexandria also just implemented in July, but again, they were setting the stage long before their implementation date. They were doing a lot of training of their PSAP staff. They participated in a lot of police roll call trainings. We're also establishing Marcus Alert call labeling procedures, working with the Regional Crisis Call Center, and established a unit for that in their CAD system. And again, they did implement in July, and they allocated their Marcus Alert budget for a Marcus Alert coordinator and 2 post-crisis outreach case managers, 1 same-day access and emergency services hybrid staff. And then partial of the funding went to a new ES crisis diversion division chief that supervises the Marcus Alert coordinator. And then ongoing PSAP and CSB staff training and department, city, and community outreach and training events. And again, with only about a month in, they identified 128 mental health related calls at their PSAP. And of those, there were 10 that were transferred to the Regional Crisis Call Center. There was 49 CIT responses that were dispatched by the PSAPs and 62 co-responder team responses. So they do have co-responder teams, they're just not funded through Marcus Alert, but they're definitely being used to help handle the Marcus Alert related calls. Then Loudoun County also did a lot of pre-work to prepare for their launch. Again, training. That seems to be the big focus. And the one thing that kind of needs to go throughout the entire life of Marcus Alert. They worked with Loudoun County Fire and Rescue, Loudoun County Police Department, Northern Virginia Community College, and the Loudoun County Sheriff's Office on small group trainings. And then they also worked with their PSAPs to update their CAD systems. And they implemented in July as well this year. They're allocating their, oh, no, that slide was messed up. So I'm sorry about that. They identified 69 calls that were Marcus or mental health related. 19 that they identified as Marcus Alert Level 1, 26 as Marcus Alert Level 2, 30 as Marcus Alert Level 3, and then 3 that were Marcus Alert Level 4. And again, first month in, they had 13 that were transferred to the Regional Crisis Call Center. 19 had a co-responder unit dispatched, and 11 had CIT officers dispatched. All right, and then we move on to Fairfax County, who implemented in July of 2023. So they have a full year in. And again, the big lesson learned with Fairfax County is that training does not stop when Marcus Alert is implemented. We've seen over and over with data that if we kind of slow down on the training, then it kind of falls out of the minds of the first responders. And we just want to make sure that the training is an ongoing thing. It's not train them up and then stop. It's ongoing. So the ongoing training efforts included the public safety agencies on the use of the Regional Crisis Call Center. They did roll call training for 911 call takers at DPSC, and they did had collaboration with the Fire and Rescue Department on the promotion and use of the Regional Crisis Call Center and the use in the field. And one of the big updates from FY24 is that they realized that the script that they were using at DPSC wasn't necessarily doing what they thought it would. So they worked with the Regional Crisis Call Center to revise the script that they're using for any behavioral health related calls, which is the Regional Crisis Call Center has crisis workers available to talk to you about your concerns and connect you to resources for further support. And then they ask if they'd like to be connected to the Regional Crisis Call Center. I know when a lot of people, if they're calling 911, I think it's important to not necessarily say behavioral health or mental health emergency, because that can definitely turn some folks away. So they did change their script to talk more about resources and support. Okay, and then Fairfax County FY24, the full year of data. shows a lot of great results. So after that full operational year, they saw that 681 calls were offered to the Regional Crisis Call Center from the PSAPs and first responders. So while that's a big number, there was a decline that they noted that throughout the fiscal year, which is again pointing to the importance of ongoing training and talking about Marcus Alert. And then there were 726 behavioral health responses in the community without law enforcement by the CSB Mobile Crisis Unit, which expanded their operations to 24/7, and by the CSB Community Response Team. So that's 726 responses to behavioral health emergencies without any kind of law enforcement. And then Prince William County were our regional pioneers in Marcus Alert. They were the first to implement, so they now have 2 full years of data. And they used their Marcus Alert funding to create an outreach and engagement team, which is a team that connects individuals in the community that are identified by first responders, schools, or other county services as needing resources for crisis prevention. And the goal of the team is to reduce the need for inpatient treatment or interaction with first responders. And then Prince William County has other crisis resources not funded through Marcus Alert, but that really helps with the crisis response system in Prince William County. So they have 6 locally funded co-responder teams that consist of a certified pre-screener, in addition to a Prince William County police officer. And those teams are dispatched through 911 for behavioral health emergencies. And then the outcome and data for FY24, which I think is some really exciting numbers, which is the 28% decrease in TDOs since initiation of Marcus Alert. So more than a quarter of folks are not being hospitalized involuntarily, which I think is just extraordinary. 533 Prince William PSAP and 12 first responder call transfers to the Regional Crisis Call Center in FY24. 85% diversion rate for the co-responder teams. 640 referrals to the outreach and engagement teams. And then just some numbers for FY24, only through March, not the full fiscal year. But their PSAP received 232,691 total calls. 5,244 of those were indicated as Marcus Alert calls. And of those, 4,081 were typed as level 1 and 2. So what that shows, as despite the fact that we're getting a lot of great results, we still have a lot of folks that aren't getting transferred to the call center that could be. So we still have work to do, but oh, I see how they wrote that it's whole FY24. Okay. That was full FY24. So there's still work to be done. They're having great results, but obviously there's a lot of change in processes, and that takes time, and culture, which also takes time. So I think as they get more used to transferring calls and seeing good results, they'll become more and more comfortable doing so. And then you probably heard the theme throughout was the need for training. So some of the initiatives that we did as a region, in partnership with HopeLink and as our regional crisis call center, is that we added a PSAP liaison. So that is someone from HopeLink who will work with just the Region 2 PSAPs and first responders. And she is a little bit of a unicorn in that she's, I believe, a social worker, but behavioral health background, but also used to work in law enforcement. So she's kind of the perfect person to go out and talk to our PSAPs, kind of be that liaison between our call center and our PSAPs and first responders, and hopefully build up some of the confidence and comfortability with both areas. And then they also just recently, they recently hired a regional quality assurance manager for Region 2 to really dive into some of the calls that are transferred to see how we're doing, if there's things we could be doing better. A lead supervisor that will be working again directly with Region 2 responses, and then 2.6 dedicated regional PSAP transfer crisis workers. So those individuals will be working only to answer those PSAP lines. So we can ensure they're getting answered quickly, they're getting answered by someone that definitely knows Region 2 resources and procedures. So yeah, we're excited for all of those. They just got the contract amendment. I'm not even sure if it's finalized yet, but it's out there. So we'll be getting all of those positions onboarded soon. The PSAP liaison's been onboarded for a couple months now.
Great.
So yeah, we're excited.
Thank you, Wendy. We appreciate it. Lots of good things happening in Region 2 as well. I'll go ahead and pass it on to Region 3, Chris Parks.
Good afternoon, Chris Parks, Regional Coordinator for Region 3. I'll start out by saying for me and for I think Region 3 will tell you the good thing about Marcus Alert is, I've said this a million times, we have a skeleton that the state gave us and we were able to fill it in how it works for our communities. So from a local and regional level, kudos to the state for that. And also for Emily and her team too, because they're very responsive when we do have questions and we need things answered. So you can go to the next slide. So 10 CSBs make up Region 3. Of those 10 CSBs, 6 of those have to implement a full Marcus Alert program. 3, as of today, have implemented their programs, working on the 4th that will, Danville, that will implement in 2025. But as far as that goes, Highlands was the pilot program, Blue Ridge Healthcare, New River Community Services are the 3 that have implemented. Those programs look very different, from Highlands to Blue Ridge to New River, who is sort of a hybrid between the Highlands and Blue Ridge. Next slide. For Highlands Community Services, in about 18 or 19 months since they actually had co-response teams up and running, over 1,500 mental health related calls for service have been answered by those co-response team members. They're averaging about 60 minutes per call. And if you know law enforcement and how busy they are at this point in time, a regular road patrol officer does not have that time. So that's the good thing, is these co-response teams actually have the time to put into the call so the person's getting the correct service that they need. Only about 13% of the calls answered by those teams in FY24, which was about 1,200 of those 1,500 calls, only 13% resulted in a pre-screen, which when I say that would be an ECO or a paperless ECO or a voluntary transport to CTAC. Only about 13% of 1,200 calls actually resulted in that person having to come into the center and actually see another mental health worker. That means that the person was actually getting the service they needed in the field. And then one thing that I know Highlands is very proud of, actually I'm housed out of Highlands, is that, and they'll probably kill me, so I'm gonna knock on wood if you can hear that, 0 incidents of use of force by those co-response teams in that 18 or 19 months. Now it could change today, but that's something that I know they're very proud of. You can go to the next slide. One thing before you go to the next slide on that, I've talked to New River, and this is something that they're really wanting to do as well, but Highlands does a lot of community engagement things with their co-response teams. They did a national night out 2 or 3 weeks ago that encompassed their whole catchment area. We also have a team that will be going to have a festival in Bristol, Virginia called Trop Rod. That is a festival for the LGBTQ community that they will be attending as well, along with some other things that are upcoming. Speaking to my counterparts in New River, they also plan to do a lot of the community engagement things. Okay, next slide. Region 3, Blue Ridge Behavioral Health, right? So they have their first full year of being up and running. To me, these numbers are fantastic. 1,607 in-person mental health calls that they responded to with law enforcement. And additionally, they were able to mitigate 294 calls by phone. So that's just over 1,900 calls that Blue Ridge was able to respond to as far as the Marcus Alert program goes. Another really good number for the 55% diversion rate on calls that would previously, before they had their program, would have resulted in an ECO. They have also expanded their hours of operation. They're going from 8 a.m. to 1 a.m. 6 days per week. And then on that 7th day, 12 p.m. to 1 a.m., which is huge. Backing up, the Highlands program does 12 hours a day, 7 days a week. I will tell you, I was on a call with their coordinator, Mandy Lee, last Friday, and she was bragging on the relationship between Blue Ridge and Frontier Health. They had an incident where Frontier Health is the call center for Region 3, where they had a consumer who was threatening suicide. They were able to get a hold of Mandy and her team in law enforcement. They were able to find the guy and get him into some services before anything bad could happen. All right, next slide. You can go to the next. Okay, thank you. Region 3, they just implemented in July of 2024. So far, they're going to have more teams. I think the plan for them is to have 5 or 6 teams. But so far, they have 3 co-response teams up and going. That's going to be one located at Virginia Tech, one in Blacksburg, and then one in Montgomery County. And I think the plans are to have at least one more in Montgomery County and one more in the city of Christiansburg. They also have one embedded clinician in Radford. And when I say New River kind of is a hybrid between the two, Highlands is a strictly clinician in the vehicle with the police, and it's co-response. Blue Ridge, a little bit different, where they respond with the police just in a separate vehicle. The one clinician that they have in Radford, she stays at the police station and kind of responds how Blue Ridge responds, right? And the other teams are that traditional co-response. Not really any data from them just yet, but I will say that talking to their local coordinator last week, they also, 2 months in, 0 incidents of use of force by their teams, which is, to me, is huge and is what the spirit of Marcus Alert is. So.
Great.
Thank you.
Thanks, Chris. We appreciate it. Thanks for all the updates. And then we can go on to Region 4. Hannah, whenever you have a second.
Thanks, Emily. All right. Hi, everyone. My name is Hannah Newkrug. I am the Region 4 Marcus Alert Coordinator. So that's Central Virginia. And yeah, just already appreciate all of these updates. I really appreciate these meetings and an opportunity to learn more about what the other regions are doing. So excited to share a bit about Region 4. So I'll just give a brief overview of the timeline for implementation in our region, give some updates on co-response for the 3 implementing localities, and then provide some high-level data for our call center and end with some regional Marcus Alert initiatives. So for our timeline, in Region 4, the first locality to implement Marcus Alert was Richmond in 2021. Chesterfield was next, the second locality in 2023. And then most recently, the third locality was the Henrico area. And they implemented just this July 2024. And while they're still in the beginning phases of implementation with Marcus Alert, just in the month of July, they've already had 18 calls diverted from their Emergency Communications Center, their PSAP, to 988. You can go to the next slide, Emily. And so now I'll give some high-level updates on the co-response teams for each of the 3 localities. that have implemented so far. So the first I mentioned was Richmond. So they call their co-response teams CRT. And their model, I know we've kind of mentioned a few different models already on this call across the state of Virginia, but their model is a clinician who rides along with an officer. They currently have one full-time team operating. And even though they are down a team, they still have maintained 212 responses over the second half of fiscal year 2024 and have maintained a 90% diversion rate with that. And an additional component for Richmond is their community focus team, which I wanted to mention as well. And that is a team that addresses the needs of high utilizers of emergency response systems. And then looking to the future a bit, they are exploring other alternative response models, looking to other localities across the state to try to circumvent some workforce challenges and meet community needs. You can go to the next slide. Thank you. So Chesterfield, the second locality to implement in Region 4, they call their team CORE. And similarly, their clinicians ride along with officers for their co-response teams, and they're currently operating 2 full-time teams. And for Chesterfield, even with being short-staffed in the second half of fiscal year 2024 due to medical leave, they still carried out 218 responses with a 72% diversion rate during that time frame. And for Chesterfield, an additional component in addition to their co-response team is something called their sprint team, which is a joint effort across behavioral health, law enforcement, social services, and other systems to provide more prevention and follow-up services to those with behavioral health needs who interact with the emergency response system. And looking to the future for this locality, they are actually in the planning process for implementing a 3rd team, which is pretty exciting. You can go to the next slide.
I think, Hannah, I apologize. I may have omitted your slide about Henrico. Do you know what you were going to write or say?
Yes, I have like 4 more slides that I had.
Did you?
Could I share my screen or
Yes,
is that?
Of course.
Okay.
Yeah, I'll stop. You go right on ahead.
Let me go ahead and pull that up real quick. That might take me 1 second.
My apologies.
Oh, it's okay. I see that we have the time, so I figured I might as well cover it.
Yeah, I appreciate it.
Right. Let's open this up here. Okay, so let me now figure out how to share my screen on Teams. Share.
It should be right. Yeah, there you go.
Okay, wonderful. Can you all see that screen?
Yes.
Wonderful. Okay, so so with Henrico, which is the 3rd locality who most recently implemented in July of 2024, their co-response model similarly is a clinician riding along with an officer. They also utilize peers as well on their model. And they currently have 2 full-time teams that are operating. But additionally in Henrico, they also have what's called their STAR team and CARE teams. So STAR was implemented actually back in 2010, and Chesterfield's sprint team was modeled after the STAR team here, which is an interdisciplinary follow-up and prevention team that strives to address the needs of individuals who interact with the emergency response system. And then their CARE team is a team within the Henrico Division of Fire that supports individuals with unmet needs. And looking to the future for Henrico, they're developing a co-response specific onboarding training. And they've, thank you to Highlands Community Service Board that they visited to try to utilize them as guidance when developing this onboarding training for their own teams. And they're also planning to dig more into the data as Marcus Alert moves forward in their locality to make process or program adjustments as needed. But a major takeaway is across these 3 localities that I've mentioned is that these co-response teams are on the daily de-escalating crises and diverting individuals from more restrictive levels of care. And at the same time, all of these teams face barriers in fully meeting the community need due to limited resources for proper expansion. I know that's something probably felt across the board. And now I wanted to take a brief moment to give some high-level overviews of some data from the Regional Crisis Call Center to try to demonstrate the really unbelievable work and dedication of those crisis workers and leadership at HopeLink. So here you'll see some highlights. So in the second half of fiscal year 2024, the Regional Crisis Call Center for Region 4 received 18,717 calls, which is about a third of the statewide 988 calls. And as you can see on the graph on the right side, calls to 988 have increased by 65% over the past half year. And this increase is due to expanded marketing and awareness of 988, but also, as Laura mentioned earlier, the process change that took place in December when the call center became the primary avenue for processing and dispatching mobile crisis responses. And relatedly, 4,980 mobile crisis responses were completed in this 6-month timeframe, the vast majority of which occurred in the city of Richmond. And this is a 546% increase over the second half of the fiscal year. And this high number can be attributed to a few factors, including the high concentration of private mobile crisis response providers in our region, the misuse of mobile crisis response by some providers, and the ongoing housing crisis, which impacts our region, but really is impacting the state of Virginia overall. And then finally, I just wanted to end with a few updates on some regional Marcus Alert initiatives. So over the past 6 months, we've worked to distribute a quarterly newsletter to several hundred Region 4 stakeholders with information and updates on the various components of Marcus Alert. I've worked with different stakeholders to facilitate Marcus Alert trainings across the region and have created and distributed this poster you see here, which I know you probably can't read, but I can send to you via email for anyone who's interested in seeing it and having it as a resource. So this is a poster that is aimed at educating CSB employees and referral partners on the various components of the crisis continuum in our region. And I'll end here with my email, and please, like I said, email me with any questions, but also if you'd like a copy of that poster, I'd be glad to send it your way.
Great. Thanks, Hannah. I appreciate it.
Thank you.
Okay, and then we can continue with our last region. Claudia usually, she's our Marcus Alert coordinator. She had a medical appointment, so we were fortunate enough to have our call center specialist, Casey, come in and provide us with Region 5 updates.
Hello, everyone. I'm Casey Mewborn. I'm with Western Tidewater CSB. I'm the Region 5 Region 5 988 administrator. So real quick, we'll go over some stats. You can see that for 2024, total number of dispatches we've received each month. These dispatches come in from HopeLink, Frontier, and our reach line. You can also see what level the calls or the dispatches were, as well as how many were telehealth and how many were face-to-face. How many had law enforcement currently involved and how many law enforcement were needed. And then the responding, so our reach hub, our central hub, adult and child, eastern hub, northern hub, and those are all CSB-led hubs. And then, of course, the total number of responses that were by CSB hubs versus private providers in our area. You can look back also at the last 3 years. Our first year we had, for the first 7 months, we had 223 dispatches. Last year was 849, and this year we're up to 1,140. So of our PSAPs here in Region 5, we have 22. Of those, 13 have signed MOUs with us to provide 90-day services. Of those, 10 have already received what we give them training on how to transfer to 988. You can see here, these are the list of PSAPs that we currently have and the number of transfers per month this year that we have. So Virginia Beach's recruitment status, they filled the Marcus liaison with Claudia Sparks. Their adult mobile crisis program has 4 positions and is still recruiting for 2 Plan 2 positions and 2 Plan 3 positions. 2 new hires started on 12/7 and Plan 2s, and 2 Plan 3s started on 1/11. I think this is their youth program filled 1 position and has 1 vacancy for mobile crisis response. They have a new hire that started on 9/21 and completed the mobile training January. They have 2 candidates selected for interviews, 1 completed interview. Did not select a candidate yet, and we'll be reposting for the MCR. Still in Virginia Beach, which is, of course, was our first Marcus area. There were no involuntary hospitalizations in October or through December. The MCR presentations were provided to Virginia Beach Psychiatric Center clinical team. The referral process, 4 new staff were being onboarded. 2 started 12/7. They will complete training on 1/26/24. And we'll be able to start assessing individuals. The remaining 2 new staff started on 1/11, and we'll complete training in February. Successful recruitment efforts are improving the ability to expand hours of services. MCR overnight hours are projected to begin by the close of the quarter. I know that they are starting to, in Virginia Beach, their adult and child team are backing each other up to provide later services a couple nights a week for children's out of that hub. ES certified pre-admission screening clinicians and other law enforcement ride together and are dispatched from the PSAP. Their hours of operation are Monday through Friday, 9:30 a.m. to 10 p.m. Saturday and Sunday, 12 to 10:30. The goal is to expand to 2 a.m. 7 days a week. For fiscal year 2023, 96% of all MCRT mobile co-response teams responded to and deferred from arrest or involuntary hospitalization. 13% of those did result in an ECO. Only 2 TDOs issued after the MCRT encounter, which is less than 1%. Hampton Newport News CSB, they were our second area to implement Marcus. Both Hampton and Newport News implemented around on or around July 1, 2023. Marcus Alert Coordinator, they have a Marcus Alert Coordinator in Hampton Newport News, 1 clinical supervisor, 3 mobile crisis counselors, 1 peer recovery specialist. They're currently recruiting for a 4th mobile crisis counselor position. Hampton Newport News plans are fully approved. Newport News Fire Department and Community Care Team, which is their CARES model. They have 3 teams now, and they're current. They have 3 teams now. They have just finished recruiting their 3rd team. And their hours of operation: Care 1 operates Monday through Friday, 7 a.m. to 3 p.m. Care 2 operates Sunday through Wednesday, 9 a.m. to 7 p.m. And Care 3 operates Wednesday through Saturday, 9 a.m. to 7 p.m. CSB team and PD for co-response operate Monday through Friday, 8 a.m. to 11 p.m. Weekend coverage is 8 hours each day, but shifts vary in time between 8 and 11. Suffolk has just implemented their program, their third area up. They implemented July 1st, 2024. We are still recruiting a clinician for the co-response team. Our hours of operation are 11 to 7. MOUs have been signed with all agencies in the catchment. Co-response vehicle was delivered in April and has been donated to the city of Suffolk. We received SOPs, standard operating procedures, from all but one agency, protocols 1 and 2. And we should be receiving that last one soon. The plan has been approved and is pending receiving the SOP and mental health policy from Suffolk.
Great, thanks, Casey. As some of the coordinators have already touched on a little bit throughout here, there's been an increased collaboration across each of the regions where we're having a lot more CSBs go to another CSB, even if they're outside of their own region, to see how they're utilizing Marcus Alert framework and what is working well and where they may be able to adopt some of those practices here. So it's really great that everyone has been working so well with one another, and even taking this time to give updates on regional things that have been working and not working. So we appreciate it. So that concludes all of our presentations. And we can open it up to questions and answers. I know we covered a lot, and it seemed like some of that went by pretty quick. I think that there may have been some in the chat. I can't read it. So if anyone would like to speak up or raise their hand.
I have a question that I put in the chat. This is Mandy from Roanoke.
Hey.
Hey, so we go to a lot of DOA calls. So whether it's a completed suicide or a DOA from a different cause of death, my PSAPs have started asking if we want a Marcus level number put on those calls because they're not actively suicidal, right? If they've already completed. So just kind of putting that thought out there. I haven't given them guidance either way. I kind of lean more towards not assigning a Marcus level to those, but I just wanted to see if that was something that anybody else has come across or what other people are doing.
Yeah, that's a great question. I don't think that that's one that we have heard from. Does anyone on the call have any feedback from Andy on what has worked well in their localities? Or if they've even encountered that before? Okay. Yeah, I don't know that I have not heard that before, Mandy, so I'm not sure. It doesn't sound like anyone else, at least on this particular call, has had that experience, but I think the next time that we get together as our regional coordinator meeting, that's something that we can bring up and have that discussion with, and maybe Chris can have some more information for you afterwards. I believe Casey had his hand up.
Yeah, and the data elements, you have, was the individual under influence? Are you asking, suspected or confirmed to be under the influence? And are you trying to track the types of substances?
Yes. Yes to all of those. So it's I don't know if anyone had posed whether it's suspected or confirmed, but it's just this yes or no data question to track substance use. Yeah, Cheryl?
Sorry, I was trying to unmute.
That's okay.
So my question was related to the data that you provided early on. There was an element where you talked about no transfer or dispatch when you were talking about the calls and which ones were being routed, I guess, to 988 or had co-response or first responder response, et cetera. What is meant by no transfer or dispatch? What happened to those calls? Did they, I mean, someone I would have assumed handled them.
Yeah, so those were coming in, we're collecting that data from the 911 call taker. So in that event when they were handling that mental health call, it's been reported that some consumers prefer to not be transferred to 988. Some prefer to just have the call stay in the 911 call center. Or maybe the call was just not applicable for it to be transferred, nor did it need to be have a first responder dispatch. So really, we're just trying to see areas of opportunities and ways to improve. So if a call does come into 911 dispatch and we're seeing an excessive amount of no calls, no dispatch, is that a training issue? Is that a consumer issue? So it's just highlighting some potential areas that some other localities have suggested.
So I would be interested in hearing from PSAPs. It doesn't have to be today necessarily. Just what exactly did they do with that call? If it didn't go to 988 and they didn't dispatch someone, how were their call takers handling that? So for example, for Hanover, we kind of have this statement that is nothing originates or terminates in the 911 center. So someone would have at least been dispatched in CAD to call this person, but it would have been a first responder, in that mindset. So I would be interested if anybody is willing to share an experience like that, just how they handled it, so that it'd be good for us to know moving forward. So thank you.
Yeah, I agree. I think it would be good information for everyone to know, is that in those incidences, how are they being handled? Agreed. Any other questions about some of the conversations or subjects pertaining to regional updates, the data changes, the Marcus Alert training? Sounds like 988 has some exciting updates, especially with the georouting. Okay. Well, you guys have our contact information for all of myself and the DCJS team as well. If you have specific 911 call taking or law enforcement questions that may not be a DBHDS question, for anyone to reach out. And I will see everyone in 6 months. Take care.
Thanks, Emily.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you. Have a great day.
You too.